So I'm coming from Barcelona. We are a quite large sports group. We are a multidisciplinary sports group. We do everything. I do shoulders and knee, but we have some people that do ankle, hip, scopes, everything. And we, of course, have a very strong physiotherapy group, which they cover most of the conservative treatment that I'm going to speak about. So my topic is basically focusing the role of the scapula in the throwing mechanism. As Nat, he said, the throwing mechanism is a cynetic chain. So the scapula is only one part of this chain. And if any of the pieces of this chain fails, the scapula, it may suffer of some of the part of the chain. So it's not always the main reason because of the problem. But the scapula, of course, is very important. If we have a dyskinesia, we have an imbalance of the muscle, we're going to have a problem in the throwing mechanism. And if we have a problem even in the lower legs, because we have a weakness, or even in the positioning of the core strength or the spine, we're going to have a bad throwing mechanism. We already reviewed the throwing phases. The Americans, they did a great work because of the baseball player. But ideally, the role of the scapula in the throwing mechanism is going to be all the time, or during all the movements of the throwing. Ideally, the scapula has to maintain the glenohumeral congruency at all times. And that will be our goal when we rehabilitate these patients. Then we have to deal with the particularities of so many sports. We have to know the technique. We have to know if they have a proper technique. And of course, we have to know the pathology. And sometimes we can have to deal with amateur athletes that they don't have a proper technique. And we have to be aware of that sometimes that would be the main reason because of the problem. So as you can imagine, the scapula, many of us, or most of us, are surgeons, and the scapula is a complex problem to deal with. Those are all the muscles that participate in the movement of the scapula and the nerves that take part of this movement. But if we at least know the basics of the physical exam of the scapula, how to fix it, we may avoid many unnecessary surgeries. Any impairment, any limitation in the range of motion, any disruption or fatigue during the season of these muscles, or any alteration of these nerves is going to alter the coordination of the glenohumeral and scapulothoracic motion, and potentially can affect the throwing mechanism. And in the long term, or even the mid-term, it can cause some structural injuries in the labrum, the calf, as we know. So what are the specific problems, and how do we detect, especially focusing in the role of the scapula? Of course, we have to do first a complete medical history. We have to know the sports. We have to be familiar with the basics of the technique of the sports. We have to know about how the pain it did appear. It was because of trauma. It was because of a maybe overloading mechanism. This is the end of the season. Maybe he was sick or he was injured in any other extremity, and then it became symptomatic after a short period of time. Sometimes that's the reason because of injury comes, because they are not in a good shape and they start throwing very intense and repeating the mechanism, trying to compensate their time out of the field. We have to detect muscle imbalance and, as we said, fatigue. Sometimes muscle tightness because of improper training or technique. As Nat, he said, we have to detect glenohumeral internal rotation deficit. We have to examine the total range of motion. Every athlete has a different range of motion. Sometimes they have 180, sometimes they have 140. It's not pathologic if the contralateral non-affected shoulder or arm has the same motion, but we have to detect that difference. Some patients, they are very hyperlax, and that's why that provokes for them to become symptomatic or have scapular dyskinesia. And of course, in the limit of the spectrum, we can have neurologic disorders. Probably most of us have seen idiopathic long thoracic nerve problems with the insufficiency of the stabilizers of the scapula. Rarely, most of the time they are hypertrophic. We can see spinal accessory nerve problems. And as we said in the previous talk, suprascapular nerves is not uncommon in shoulder throwers. So how do we evaluate scapular dyskinesia? How do we detect? Well, first we do a physical exam, of course, after the medical history. We do the physical exam in the front, but mostly on the back without the shirt is the way we're going to detect these problems. We have to see the static of the scapula, and ideally we want to see the black line. Normally, the scapula in the resting position with a good muscle balance is going to have like about 5 degrees of up tilt towards the deltoid. If we have the red line that or is very prominent, the tip of the scapula, we probably have a bad starting point for the sliding over the thorax of the scapula. And if the scapula is not congruent with the movement of the humerus and the shoulder, we are going to have probably impingement problems, like a high riding humeral head, and that is going to introduce over time in impingement injuries, rotator cuff impingement syndromes, labral tears, biceps problems, etc. We have to do a dynamic exam. Sometimes it's more clear than others. In this patient, we may not know what exactly is happening, but we can see that there is no symmetric movement of the scapula. So what happened, he has an insufficiency for any reason of the muscles that stabilize the scapula, the trapezius, the rhomboid, and the serratus anterior, and that's why he has a scapular dyskinesia. It may be the original problem, or it may be provoked because of an original injury of the shoulder. In any case, the treatment is going to be similar. If we cannot detect exactly this scapular dyskinesia, we can do provocative maneuvers. We can ask for the athlete to do that movement, forward flexion of the shoulder, with some weight, and that's going to provoke more scapular dyskinesia. Or, as Ben Kibler described it from the US, he described the scapular assistant test, which is like just helping the scapula to go with the humerus, and the patient is going to feel some improvement in the pain, and it's going to facilitate the movement. And this test, when it's pathologic, it means that we have to reinforce the periscapular muscles treatment, conservative treatment. Or on the right, another provocative maneuver is the scapular retraction test, which means many of these athletes, it's not exactly scapular dyskinesia, they are just protracted. Many of these throwers, or for example, the swimmers, they very often have a protraction of their shoulders, and because of the continued training in this position, they got subacromial problems, labral problems, even kind of laxity or instability problems with even some noises, some like subluxation symptoms, and this is because they are completely protracted, and we have to correct that static position. And one way to detect that is to help the athlete during the exam to retract the scapula and see if he gets some improvement in the strength of his rotator cuff, and very often they do. GER, it was defined before. It's not defined with any number nowadays. It's defined as a loss of internal rotation in the presence of loss of total rotational motion. As we said, every single person or athlete has a different range of motion, but we have to detect if there is a difference in the complete arc of motion, rotational motion, in between the dominant or throwing arm comparing to the non-dominant arm. And especially the internal rotation deficit, if we detect that, that means that we have to work in the stretching the posterior capsule, and that may correct the scapular dyskinesia that the athlete is presenting. So we detect some problems with the scapula because of our physical exam. What do we do next? Well, I would say that almost in any of these scenarios, unless there is a clear structural traumatic or like severe structural injury of the labrum or the calf or anything, almost in any scenario with a scapular dyskinesia in an athlete, there's an indication for conservative treatment. At least we should try. We have to work in the stationary position of a retracted scapula. I can remember how many times I spent sometimes with Buddy Sawa in Tulane. He treated a lot of athletes from New Orleans, college athletes, and I cannot remember how many times he insists to the athletes to retract their position, or non-athletes, even patients with rotator cuff problems. We know how important it is that they get a right position with whatever task they are doing in their daily lives. We have to stretch the posterior capsule in case of internal rotation deficit. And of course, we have to rehabilitate the periscapular muscle and the calf muscle. And in throwers, we have to detect if there is any problem in the rest of the kinematic change components, as can be the core strength, the spine, or the legs. That's a way to stretch the posterior capsule, and that's one very basic exercise, which is called low row. She's pushing with the right hand to that chair, to that kind of chair, and he's pushing back to reinforce the muscle that stabilizes the scapula. So what would we do if the conservative treatment fails? Well, hopefully we have a structural injury, because if we're not, it's very difficult to take a decision to go to surgery. But sometimes you have to do it. Sometimes the imaging studies, they're not going to show clearly an injury, and sometimes after 1 year or 2 years of good rehabilitation, if they're not improving, sometimes with the scope you can see the real injury. But most often with the modern MRIs, 3 Teslas or arthrograms, we can detect even small injuries. And those are the injuries that we're going to detect. Most of the time, they are accompanied with scapular dyskinesia. As we know, we detect many, many labral injuries. I have the chance to spend 1 year at the University of Florida. We took care of Florida Gators, and I spent time with Mike Moser. He's the head of sports medicine center there. And we treat a lot of shoulder problems in baseball players, handball, football players. So we repair many, many of these slap injuries and posterior labral injuries. We have the Kim lesion, biceps, poly problems. That was popularized by Craig Morgan, the problems in the superior glenohumeral ligament, the anterior aspect of the pulley of the bicep, that very often we don't pay attention on them. And his theory, he has a study with almost 30, 40 cases that fixing this anterior pulley of the biceps, he can skip a biceps tenodesis and make better the throwers. We have to detect glenohumeral instability, if it is because of structural injury or because of the malpositioning, subacromial impingement, internal impingement, partial calf injury, and of course, AC joint problems. And to finish with, when we have a structural problem, to me, surgery, the indication for surgery, is a patient with this kind of scapular dyskinesia that is not compensated with the conservative treatment, and hopefully we have a structural injury, mechanical symptoms, and a confirmatory MRI. And the last very important thing to say is to ask to the athlete if he's able to compete. Because if he's able to compete 100% or almost close to 100%, even if he has this kind of pain or problems, I would recommend to not operate on them. So I would just go to surgery in this kind of throwing athlete problem if he's not able to compete. And because we are surgeons, I just want to show a very fast video, 1 minute video, if I can. Thank you. One of my last patients, he's a 21 college tennis player. He's from Spain, but he was playing in the US at the college level, which is a quite good level, and his scholarship is depending on his performance in tennis. So he came to Barcelona asking for help, because after 2 years of conservative treatment, and I guess a good conservative treatment because he did it in the US, if somebody has experience in rehabilitating shoulder and scapular problems, are the therapists in the US. And when we went inside, we saw that posterior inferior or internal impingement problem with the frayed, deep layer of the rotator cuff, and this not very deep, but quite clear injury in the posterior superior labrum. In these cases, it's just the posterior labrum is the one who is injured. I always try to avoid to do a tenodesis, especially in throwers in such a very young age. And of course, I wouldn't placate any kind of capsule, and I wouldn't repair the rotator cuff, even this is a past tear, because you can limit his external rotation. That can be the end of the career of any thrower. Thank you.